Welcome to Pioneers in Medicine. I'm Bruce Gewirtz, Vice Dean for Academic Affairs and Surgeon-in-Chief here at Cedars Sinai. And today it's our really good fortune to have my good friend Mark Vrahas, our distinguished professor and chair of the Department of Orthopedic Surgery. Mark, welcome.
Thanks for having me. It's really fun to do these kind of things.
My pleasure. So, I'm very aware of your history, but tell us a little bit about where you grew up and how you got interested in medicine.
Well, I grew up in rural Pennsylvania, and my mother was a nurse, so that gave me some interest in medicine from her, although it wasn't. My family was in the restaurant business, so I was also interested in the restaurant business, but my dad was very clear that medicine was a better choice than the restaurant business, and went to school not necessarily wanting to go into medicine, but ultimately thinking this would be a good thing to do. And I went to University of Pittsburgh for my medical school, stayed there for a residency in orthopedic surgery. That in itself is a little bit of an interesting story, because I went to medical school, not sure, didn't think I was going to get in, and I thought I was going to go. At the time, I was doing a project on a microcomputer that had just come out, and was invited to be a grad student at the University of Washington in microcomputing, which ultimately would have been much more lucrative had I had gone that path. But I went to medical school and hated the first 2 years, and was about ready to quit. But they had a summer research program, and I was walking down the hall and looked into a lab, and they were crushing these bones, and I thought, man, that looks like it'd be really fun. And so I worked in that lab in the summer, and then got interested in orthopedics and really motivated about medicine and orthopedics, and then progressed through. And as I went through, got interested in the subspecialty first of complex surgeries around the pelvis, but then as I got more and more into that in fellowship, that developed into an general interest in trauma, orthopedic trauma, which is at the time in 1980s was undergoing a revolution, that a whole different methods of treatment and not many people in it and that sort of thing, but it really sparked my interest. So I went to Toronto for a fellowship, and then spent 4 months in Europe in fellowships there. Ultimately came back and was in New Orleans at LSU and Charity Hospital for 9 years. And from there moved to Harvard as the chief of orthopedic trauma for Mass General Hospital and the Brigham when they were combined in that way. Loved my job there, was there for 18 years, had no intention of moving, but Dr. Gewirtz convinced me when I came out to visit my son who was at USC that this would be a good move, and it turned out to be that way. So I've been here now 5 years, which has been great.
Yeah, well, it was certainly a good move for us. One thing that I have noticed, particularly since you've been here at Cedars Sinai, but even before, is that it used to be that just any orthopod took care of trauma. It was just part of the broken bones that were the field. But as the discipline has become so subspecialized that the sophistication and outcomes from traumatic injuries have improved so very much. What would you describe as the drivers of those improved outcomes?
Well, I think, it was a whole change in the way that trauma and fractures were looked at from the general orthopedic community. So when I was a resident, trauma fractures were relegated to the lowest, the newest person on the staff. They were inconvenient. They came at times that were, you didn't have scheduled operative time to do the breaks and those sorts of things. And that was really around the world. And there was an interesting group of Swiss surgeons who got interested in the fixation of fractures. It was in Davos, Switzerland. It was a big ski area, so they got interested in how to get people back to life better. So they got very interested in fractures. designed the first really good implants. And more importantly than that, they for anybody that was going to use these implants, you had to go to Davos and take a course on how to use them. And that translated into a whole continuing medical education program that surgeons around the world, every resident in the United States, takes one of these courses now. And those people, there were the people who were first interested in it and went and took these courses, they became part of this group, which was the first networking group in trauma. So it was in those days there weren't no orthopedic resident in their right mind went into trauma. When I was a resident, nobody wanted to do that lifestyle because there was no operative time during the day. You only operated at night. It was getting where places needed to have one of these people, so they were all anxious to hire somebody like me, but their idea was, okay, we got somebody that does trauma now, we never have to operate at night again. So that was the impetus. So first years for people that were in trauma were, basically up all night every other night and doing that sort of thing. And it became obvious everywhere that people that trained in this and took an interest in it and understood it were getting far better outcomes than the way that it had been managed before. And through that recognition, that spread to it become people interested. Enough people got interested in it, built the specialty, and remained difficult for several years. But then as we studied, it became more of a priority for every hospital to have people that knew how to manage this. We also were able to get operating time during the day. It became and build teams that manage these patients. So I think, to go back to answer your very first question, what made the big difference were people that were interested in this and developing and getting better and researching to find better ways to manage fractures and manage the care of patients.
One of the things that you've brought here, I know, has been an orientation to better measuring the outcomes of care and better assessing the, for lack of a better term, the psychological well-being of patients that you care for. Could you tell us just a little bit about how you do that?
Yeah, well, we it was having been in trauma and seeing a lot of my patients that had, problems with PTSD and post-traumatic stress disorder and depression after the injuries, and how I always had sort of an interest in it, as well as the general idea that what we should really be focusing on improving is the patient's perception of their well-being, in their opinion, not in our opinion. I can take an x-ray and I've done a terrific job, but if the patient doesn't feel that they've improved or they can't function in a way that they want, then we haven't necessarily improved the care of the patient. So it came to the feeling, two things. One, that we needed to get unbiased opinions from the patients of how our work, how we were succeeding in their care, so we could further improve our care. And the second was it was more recognition among trauma that the psychological factors played a very important role in their treatment. So we also needed to include that in the evaluation of a patient. Were they having problems with psychological factors that could be affecting their overall outcome? So we could make their bone heal perfectly, but if they're depressed or if they have PTSD, their function and their general health well-being may still be terrible, no matter how well we fixed the bone or how well it healed. So I got interested in measuring that, as many people did around the country, and we started to measure that. We quickly found that depression markers are very prevalent in the patients that we take care of. It's not something that we sort of didn't predict, but we never really measured it and looked at it. So when we started looking at it in our clinic, we had 3% of our patients who were severely depressed and 16% who were significantly depressed. And it was valuable because we were asking the patient these measures, like standard measures created by the NIH, to find out if they were depressed. As an orthopedic surgeon, somebody coming in to see me, I don't normally ask them about their depression. I ask them about their bones. So we started seeing this, and we said, wow, we really have to address this. So we said, well, at least we'll make sure that the treating orthopedic surgeon knows about this problem. So we developed some things in the electronic medical record. So when one of these patients filled out a form that said they had signs of depression, we'd send a note to the doctor and say, hey, this patient has depression. So we wanted to know if that was being effective, so we did a little study to see if that was effective, and it was better than nothing, but only 30% of the time did the surgeons act on it, or at least we knew they act on it. They put something in the chart that said. So we thought we needed to do better than that, and we actually then hired a social worker and embedded that person in the clinic, which has been a huge godsend, because we identify somebody like this, somebody skilled in managing these problems, can come in and talk to the patients, can connect them to resources outside the hospital, make sure they're getting the proper care. And it's been, our surgeons have always felt like, we should do a better job with this, but we don't have time to do that. Having this person has made everybody loves having the person in the clinic to help manage these very important problems for the patient that affects their general quality of life and health quality of life. And we weren't addressing it appropriately. So that was really valuable in our clinics.
No, it's really insightful, and people tend to think of us surgeons as being somewhat neglectful of those kind of sort of cognitive interpersonal things, and I think it's really to your credit that you got involved in that. I also know that the other area that you've had a fantastic impact, and you brought some personnel from Boston to focus on, is geriatric fractures. And I think we're all aware of how a senior can deteriorate following a femur or hip fracture, and have a real diminution in their ability to enjoy life and their subsequent thriving after the fact. I wonder if you could tell us a little bit about your view of that, and what measures you've taken to improve the outcomes of geriatric fractures.
Yeah, it's interesting because, as we've talked here already, my interest was in trauma, and in those days, in the early 80s, 70s, late 70s, early 80s, when I was beginning, trauma was big trauma. It was car wrecks. Seatbelts were not used very much. There was, a lot of drunk driving, a lot of things. So we took care of a lot of high energy injuries, which was the interest of most trauma surgeons when they were coming into it. The multiply injured patient, how do I put this person who's really been cracked up from the motorcycle accident or the car wreck or whatever, and these very complex fractures that occurred. So we had two things that happened, and one was, for very good reason, from interventions in automotive safety and interventions in seatbelt and Mothers Against Drunk Driving, and great work from trauma societies, both general surgery trauma societies. The incidence of those kind of injuries went on decline. At the same time, we have this population getting older, and turns out, an older person with weak bone, with a low energy fall, can have every bit as complex of injury as the person that had a major car accident. So by necessity, as the population was shifting, we started to get interested in that. Now, we don't think of people. I always think of it a little funny because when you're out and we're talking to various people around, it's not a very sexy topic like fractures in elderly or geriatric fractures. It's not a sexy topic. People want to hear about how we're curing cancer and how we're fixing Alzheimer's disease and all that. Understandably, obviously those people don't think about their fracture they might get when they get older. In fact, they almost certainly will get. If you look after the age of 50, 1 in 2 women, 50% of women will have what we call a fragility fracture. So a fracture from a minor fall. And 1 in 4 men will have a fragility fracture. So it's a huge, everybody, as we get older, the risk of that gets really high. But nobody ever thinks it's going to happen to them. We all think we're young forever, so no one ever thinks they're going to get a fragility fracture. They worry about getting Alzheimer's or some other thing, but they don't really worry about falling and getting hurt. It's not something that they think about. So it wasn't a very sexy topic, but it was one that I saw as very, very, very important. Even if you look at the numbers, there are about 2 million what we call fragility fractures in geriatric older patients, about 2 million a year compared to 800,000 strokes and 800,000 heart attacks and 300,000 cases of breast cancer. So it's a big thing, and it almost always affects people's lives. Older people that might have been living alone have more difficulty living alone after a break like that. They have more difficulty doing the things they want to do, although we've gotten very good at the surgery. We can get their bones to heal, but getting them strong again, getting them not to be worried about falling, all those sorts of things are a hard thing. Now, we got good at surgery, but as we're looking at things, we're worried that what was really important in their outcomes wasn't changing, which was for a substantial number of older patients, say with their 80s or in that age and beyond, the fall, about 30% of that elderly group, it's their terminal event. It begins a downward decline after they have their fall, that they get pneumonia, they get various problems, and ultimately dwindle. So we wanted to improve our outcomes, not just in getting the break to heal, but getting them back to better life and back to and preventing that, decreasing that 30% by getting them back to work. So we started looking at how do we do that, and recognized that one of the biggest problems was that the way we dealt with these breaks was as a health system, not just our system, but across the country, the way we dealt with these was through a very fragmented system. So when a person has a hip fracture, they can they have to be managed medically because they have medical problems at that age, and they need the internists need to work with the orthopedic surgeons, who need to work with the therapists. But because everyone was siloed in their treatment, it was never a coordinated effort. So there was never the ability to really optimize the care of the patient because the treatment was so fragmented, delivered here and delivered there, and without a coordinated effort to try to develop protocols to do the best thing to prevent these long-term things. And what's even worse than that, we actually have very good methods to decrease the risks of fracture. So if by appropriate treatment for osteoporosis, we can decrease the risk of a fracture by 50%. Only 10% of the elderly people in the United States get appropriate bone health management. And then even beyond that, we also know we have very good ways, at some point, the strength of the bone becomes less important than preventing people from falling. And as people get older, they lose balance, they lose things, and there's actually scientifically proven methods for helping people maintain better balance. Actually, Tai Chi works really well I suggest to a lot of my patients, through Tai Wise and various things, Tai Chi is a really good way to do it. And we have a program here at Cedars that we got a grant from AARP where we put patients these elderly patients who had fragility fractures. We put them into these programs that are documented as helping this, and we've been able to show that we can reduce the recurrence of fracture. Because if they have one fracture, if you have one break, so somebody falls, they get a hip fracture, 30% of them will have a second fracture within a year. So by putting them into these programs to help prevent their falls, making sure that their house is appropriate, they get rid of throw rugs, they put rails up and things like that, we can decrease their risk to the fall. What we're really interested in doing, and what our program does now, is not only we now want to influence that whole cycle of care. So we've set up processes in place where we now can try to capture patients before they have their fall, so we can get them appropriate bone health management and get them cognizant of these problems. When they do fall in the hospital, we've developed a program that includes our geriatricians, our physical therapists, our internists, and all our hospitalists, where we all work together to protocolize everything and follow pathways, so we do that. And then we have nurses and care managers that follow up with the patient after they leave and their family. Are you having issues at home? Are you having problems? We follow up with their primary care doctors, with the goal of really wraparound treatment through the whole cycle of care, rather than what was before, fragmented care all around. So it's not curing cancer, but we think it's an important contribution. And we've been able to publish many papers on our interventions, including how to better manage the pain for patients when they're in, how to set this program up and running, because there's only a limited number of places in the country where they've done this, and we've developed a model for how to do it, and then various aspects along their care, how to prevent the next fracture, how to get them into bone health treatment. We've written papers on all that, and it's one area we're very proud of.
Well, it really is extraordinary, and the interesting thing about it is, as we've looked at it more centrally, although you enumerated a number of resources that have gone into this, the actual cost of the episode of care has actually declined, because obviously the patient doesn't bounce back with another problem. And the other thing I like so much about the work that you've done is that it shows that our patients exist in a social system, and physicians have been criticized, not just orthopedists, but all of us, as dealing with episodic elements of care without taking care of the whole patient. And I think it's one of the great things that you've brought to Cedars Sinai, the visualization of the social milieu in which the patient works. So we're deeply grateful for your thoughtful comments today, and particularly the great work you and your group have done.
Well, thanks. It was really nice to have the chance to talk about it.